I would like to welcome you all to this session. It's a great pleasure to chair this roundtable with distinguished speakers. Their expertise and insights are highly anticipated as we move towards establishing the future priorities and focus areas for the healthcare system of the country. Let me first introduce our speakers. Mary Harney, former Deputy Prime Minister of Ireland, Minister of Enterprise, Trade and Employment, and Minister of Health and Children. Thank you, Mary, for coming. Julie Gerberding, former Director of the U.S. Center of Diseases Control. I call Julie the Iron Lady of Public Health in the U.S. And she's an Executive Vice President of MSD in the U.S. And Sarbani Chakraborty, she's a Senior Health System Strategy Leader in Roche Pharmaceuticals with the capacity of driving partnerships between stakeholders and governments. Unfortunately, Elias Mossialos did not make it, so we are the four of us. Just an initial comment before I give to the speakers the time to provide their insights on the topic. There is no doubt that the Greek health system needs to exit a long-lasting crisis and move towards a new era of value-based healthcare provision, sustainability, and responsiveness to patients' needs. We don't have to reinvent the wheel. We strongly believe that it's about time to adapt already available tools and technologies to meet the long-awaited efficiency targets and improve the healthcare system of the country. No doubt, health performance and economic performance are interlinked. We all know that wealthier countries have healthier populations. So we must convey a clear message that investments in health and the design of health financing policies should be addressed in terms of the interaction between health and the economy. With no further ado, I would like to ask Mary to share with us her thoughts.
Thank you very much, and I'm delighted to be here. This is my second time to attend the Delphi Economic Forum, and I certainly enjoyed it enormously the last time, so it was very easy to say yes when I got the invitation to be here on this occasion. I'd like to acknowledge the presence here of Her Excellency the Irish Ambassador to Greece, Orla O'Hanrahan, and her Deputy, Marianne Bulger. All politics is local, so I have to mention the local people first. It's also interesting that the three panellists are female. The chairman is male, obviously. And the healthcare system is being feminised around the world. I recently had an opportunity to speak in the UK to some medical students, and it was hard to find a man in the room. These were fourth-year medical students. So I think we're arriving at a situation where healthcare is going to be feminised. Can I say I'm very pleased that healthcare is put in the context of inclusive growth, because far too often health is seen as a problem and merely a cost. Finance ministries often feel that putting money into health is like putting it into a big black hole. I believe good health policy is good economic policy. We only have to look around the world at the poorest places and to see what the state of their healthcare system is. In Africa in the 90s, for example, their economic growth was three times lower than it might have been because of the HIV/AIDS epidemic. Whether it's the WHO or the European Union in their jobs and growth strategy, everybody acknowledges that health policy is central to smart and inclusive growth. There are no silver bullets when it comes to reforming the healthcare system. Our systems were established to deal with acute episodes of care. such as malnutrition, infectious disease, and so on. And this industry has not been disrupted like so many others, and disruption is on the way. And unless we're ready to embrace that disruption, it's going to overtake us. Companies that are not traditionally in the healthcare space are now embracing it, like Google and Walmart, etc. In Europe, 80% of the healthcare budget is consumed by chronic illness. The good news about health is that we're living longer. The bad news is that we're living with at least 2 chronic illnesses if we're over the age of 65. And that is consuming 8 out of every 10 euro of the budgets across the European Union. And that is the challenge. How do we ensure that we have a quality healthcare system that's universally acceptable but also affordable, where people can have healthcare in a timely fashion, in the right place, delivered by the right person? That requires enormous reform. And there are reforms happening around Europe. There are pockets of wonderful reforms. And in our opening remarks, we've been asked to mention some of them. Here in Greece, for example, in Patras Hospital in Athens, major reform there has delivered huge benefits. The introduction of lean technology, for example, has reduced the infantry by 73%. New procurement policies have saved 24 million over 3 years. Taking non-clinical tasks away from nurses has increased their productivity by 33%. And if we were to apply that nationwide in Greece, that would save €1 billion a year, and it would give us 12,000 extra nurses. In other places, Kaiser Permanente in the USA, which is one of the best health systems in the world, it's both a provider of healthcare and an insurer. They have shown that for several chronic illnesses, including hypertension, stroke, etc., diabetes, they use 1/3 less bed days than the NHS. Why? Because they're technology friendly, they communicate, they've integrated care, and they've huge incentives to keep their patients well by the patients managing their illness. Musculoskeletal disease is the main reason why people are off work. In Europe, every year we lose 2% of GDP, or almost €300 billion, as a result of people being off work. In Carlos Hospital in Madrid, a very dynamic doctor, Dr. Juan Hover, that I had the pleasure to be on a working group with, the European Steering Group on Sustainable Healthcare, sponsored by AbbVie a few years ago. He showed by early intervention he could reduce permanent disability by 50%, temporary disability by 40%, reduce the complexity of the healthcare intervention, reduce welfare payments, have people back to work earlier, and enhance productivity. And the cost-benefit analysis was €11 benefit for €1 expenditure. I mention these examples because sometimes we believe that there is nothing we can do about the problems. There's a lot we can learn from each other. But above all else, what we've got to do is be on board for reform. And that means we have to reform how we pay for healthcare. It is no longer sufficient to pay for pharmaceutical products based on volume. It has to be based on value. How do we make that happen? There are many ways of doing that: mortgage-type payments, reinsurance, value-based on the results to the patient or the results to the system or whatever. We need data, we need technology. There are huge issues around putting data into healthcare systems. Less than 10% of hospital facilities in Europe are provided through M.Health. Huge potential if we can capture the evidence to allow us to be able to pay based on results. And lastly, can I say, the new therapies, the new gene therapies on the way, science is producing game changers, but the challenge will be, can we afford them and how can we pay for them? In the music industry, we no longer buy records or CDs. What we do is we subscribe to Spotify or we subscribe to Netflix for our films. In the future, perhaps we'll be subscribing to pharmaceutical products, where we will subscribe to the IP and then we will get the product and it won't be based on the volume or whatever. These are new ways that we have to think, but we haven't got a lot of time to make them happen. And how do we make them happen? We make them happen by industry, patients, healthcare providers and policymakers working together. And we have been slow in the industry to make that happen. Take, for example, antibiotics. We know that in the world at the moment, 700,000 people a year die as a result of antimicrobial disease. That's estimated to grow to 10 million a year by 2050, 10 million. We haven't really had any new antibiotics. Why? Because the innovation wouldn't pay for itself. I know that the Innovative Medicines Initiative in Europe has 650 million involved in several projects in this space. I think there are 8 projects. If we don't get new antibiotics, some of the basics in healthcare, like hip replacements and knee replacements, and the things we take for granted, will not be possible. The CMO in the UK has spoken very frequently and very loudly about this, appealing to industry to bring forward new antibiotics, and industry won't do it on its own if they're not going to be paid to do it, and that's why I'm a supporter of the Innovative Medicines Initiative, which involves the Commission, industry and the biotechnology industry. Ladies and gentlemen, the hospital of the future will be your phone. You'll be able to self-diagnose in many cases, send the data into a central bureau where your physicians will work around you rather than the silo system we have at the moment. Above all else, we have to make sure that patients can manage their illness. Well-managed illnesses reduce hospitalisation, reduce emergency department attendances, reduce expenditure on health. We have to use the technology that's there now in a much more smarter way. There are over 300,000 health apps. Very few of them are being used in any kind of a meaningful way. I'll end with those opening comments. I'm looking forward to the engagement, and in particular I'm looking forward to the questions, because I see in the room some people I know from industry and from the healthcare professions. But I will say this: without disruption in the way we do business, the status quo is no longer an option. There's an urgency, if we in Europe want to adhere to our values of providing good healthcare on a universally accessible basis to all our citizens, to act to make sure we deliver the kind of change. And as a former health minister, I don't underestimate the task involved in delivering the change, and it can only happen if we're all agreed on the way forward and we work together to make it happen.
Thank you very much. Sarbani, please.
Thank you. Good afternoon, everybody. And again, thank you for a great opportunity to be here. Perhaps something I was not mentioned, my background really is in economics. I worked for almost 17 years with the World Bank. And in that capacity, I spent a lot of my time working with ministries of health. And one thing I would like to reiterate, whenever I talked about health with ministers of finance, they said, we don't understand it. For us, it's like putting money into a black hole. And so one of the things, picking up on what Dr. Harney just said, if we have to convince ministries of finance to invest in health, we have to make it much more transparent and much more accountable. So with those opening remarks, I'd like to bring to the table a few thoughts about how we at Hoffmann La Roche think about partnerships and the importance of using partnerships to drive disruptive healthcare. So who is Hoffmann La Roche? We are a Swiss-based healthcare company. We work not just in pharma, but also in diagnostics and diabetes care. And we put a lot of emphasis on working with the health system to transform healthcare for patients. So from my perspective, picking up on some really important points that was made earlier, I think there are a couple of major disruptions happening in healthcare now. And if we don't pay attention to these changes, we're going to be late to the game. So one of the critical issues, and I think I'm talking to an audience that knows this very well, every single European country today is struggling to deliver better quality health services. As you know, there are two major trends: aging population and chronic diseases. But at the same time, more and more patients these days know about innovations coming to market, and they're asking their governments, how can we afford those innovations? So governments need to be accountable, but this also puts governments in a very, very difficult situation. They have a limited budget, and they have to think, how do we bring innovations to the health system? And here, instead of making the job for governments harder, we as the private sector need to be a solutions partner. We can no longer say, it's the problem of governments. No, it is all our problem, and we need to think jointly about access solutions. So what are some of the access solutions that we at Roche think are disruptive? One is the fragmentation of health systems. Health systems are extremely siloed, and they greatly increase the cost of delivering healthcare. So there are some studies which show that it takes about $10,000 US to deliver the same care in a fragmented health system versus 5,000 in an integrated health system. So one of the questions to all of us is, how do we better integrate health systems so that the experience of receiving care for the patient is better, and it also delivers better value to the health system? If you think from the patient perspective, navigating a fragmented health system costs patients and caregivers a lot of time and money. There are repeat tests, but caregivers have to navigate the system. When I worked in Asia Pacific, one of the big projects the World Bank did was to introduce a patient navigator system, because people simply didn't know, do I have health insurance or I don't? What is covered and what is not covered? So helping patients better navigate the system is terribly important. The second point from our perspective is prevention. And I'm speaking as a public health person. No country in the world today can deliver affordable health care if we don't talk about prevention and early diagnosis. We all have to be really committed to it, and we have to prevent what we can prevent. I often think of type 2 diabetes, which, as you know, is a pandemic globally. But we know that addressed and tackled early on, diabetes is very manageable. And as Mary just said, there are apps and other instruments which are available. But the question is, these are still pretty hard for patients to use to really change lifestyle. And there, since the topic of the conference is inclusive economic growth, what we do know is that it's especially hard for people in lower income categories to change their lifestyle. So we need to be thinking inclusive. How do we address the social determinants of health? The other, which Mary touched on, which is very close to our heart, is digital transformation. This is the fourth industrial revolution in health. Actually, health is very late to the game, but things are happening out there that we need to start using. So one of the things that we often talk about, which also picks up on Mary's point, is how do we have integrated decision support systems so that the healthcare system talks to each other? So it's less fragmented. How do we empower providers and nurses and others to be able to use these systems to improve the care process? The other topic about human resources is, we know oncologists and other care providers are overburdened. How do we use task shifting to begin to change the dialogue? And then finally, I would like to make two more points. One is on data and costs of healthcare. If you look at cancer, we actually know very little about the costs of delivering cancer care. And this is the reason why the OECD is now talking about disease national health accounts. It's really important. And finally, what is the role of the private sector in all of this? As I said, I'm new to the private sector. But one of the things I've learned is, if the private sector does not work with the public sector to change how we are delivering healthcare, we will lose our presence. So we need to be a part of the solution. In addition to that, if you really want to transform economic growth, in my mind, you need three important pillars. One is unleash the power of private business, improve health, and improve education. And the private sector has an incentive to contribute to a better educated, healthy population. So work with us. We are here to find solutions jointly with you to drive disruption in the health sector. Thank you very much.
Thank you, Sarbani. Julie.
Good day. Thank you so much for including me here, and I appreciate the erudite words from our previous panelists. I'm going to focus a little bit more on health and the health opportunities as a growth driver, and talk about it from the perspective of someone who's both worked in the public health environment, but also in a business that is looking for places to invest resources to try and drive the life sciences business. The first thing that I would say about Greece is that there is a tremendous opportunity here in terms of the indigenous assets. have an educated workforce that can participate in health and life science development, experience to some extent with clinical trials and the environment where science can be created to make decisions about drug and device development, and amazingly, an incredible resource in the health data that have been accumulated through the electronic health records that have been developed in Greece. But we also have to look not only at the asset base, but what are the requirements for investment? So just speaking from the perspective of one company or one sector, but also I am on the executive committee of the trade association in the United States called BIO, which represents the entirety of biotechnology. And I know what companies look for when they're making decisions about where to put their assets and their resources. Intellectual property protection is one very critical factor. Regulatory predictability is a second, so understanding how the regulators will respond to innovation and health and technology opportunities. And then third is really the market overall, a country willingness to pay for innovation and to recognize that you can't have investments if you don't also create business opportunities. So having kind of laid that context then, what could be the opportunities for driving that kind of economic development here? There are some ways to create headroom for the investment. I'm going to divide them into immediate, sort of midterm, and then longer term opportunities. From the standpoint of the immediate outlook, the first and probably biggest opportunity is waste. I'm sure it's true here, across Europe, the US, and in many other countries where we have a lot of unneeded care. We're spending money for things that aren't really delivering the value that Mary talked about, whether that's unnecessary drugs, unnecessary interventions, unnecessary hospitalization is probably the biggest player overall. And so we really do need to move toward an environment where we eliminate that waste. Second, we need to utilize generics and biosimilars much more ubiquitously and at prices that are more commensurate with the opportunities that have been used in other countries. If we treated hypertension, high cholesterol, and diabetes with generic drugs and encouraged adherence to them, we would avoid a tremendous subset of unnecessary costs related to the complications of those illnesses, and particular hospitalizations that are completely preventable. Treating those three conditions is cheap. In most countries, you can treat hypertension for a few cents a month. So the opportunity exists to identify and move the population in a direction of better management of those conditions. I think, of course, in this bucket is also preventive care, and certainly some vaccines save money now. For example, pneumococcal immunization of old people reduces hospitalization and is a cost-saving intervention. Likewise, these days, with the outbreaks of measles and other childhood illnesses, immunization for childhood diseases is cost savings, both because of the tremendous burden that outbreaks place on individuals, but also the burden on public health to have to investigate and intervene to manage all of those cases. Now let me talk briefly about midterm opportunities, which are sort of the cost-avoiding opportunities on a larger scale. The idea of value-based care is important, but it isn't just a matter of drugs demonstrating value. We need to have value-based care across the continuum. And the biggest opportunity there is probably to take advantage of health technology and move care upstream so that people are not requiring inpatient or expensive interventions. Increasingly, with health technology, they can be managed efficiently at home and in ways that cost far less money. I would also put some vaccines in this category of cost avoidance. We may have to invest today, but downstream, things like hepatitis B or HPV are cost-saving vaccines because of what they cost from the disease burden years later as the cancers and other complications accumulate. And last in this compartment is the notion of screening. Screening may involve upfront costs, but in the midterm horizon, again, the avoidance of more expensive downstream care is substantial. And I'll just use the example of lung cancer, where we know now from evidence across several countries what constitutes a high-risk patient for lung cancer. And we know if those patients are screened, they can have surgical intervention at a much lower price than what it costs to treat them downstream with expensive chemotherapy, radiation therapy, hospitalizations, and so forth. So making the case for more aggressive screening programs is sensible. Finally, in terms of long-term health protection, where we get the biggest value but takes the longest to appreciate it from an economic perspective, really falls into the category of health in all policies. And what do I mean by that? I mean, health isn't really created in the hospital. Health is created at home and in schools and in the workplace. And by investing in prevention and wellness in those environments through policy changes, over a long run, you can achieve tremendous population health benefit. Health in all policies includes things like sidewalks, inducements to take stairs, healthy nutrition in the workplace or in the schools, and various other dimensions of nudging people into better health that don't necessarily come out of the health minister's budget, but reflect how society invests in the environment and the overall social construct in which care and health are created. And finally, in the long-term category, and probably the one that's the most interesting to me personally, is innovative finance. And I liked what Mary said about moving from sort of prescriptions to subscriptions. There are lots of opportunities for creative ways to spread the costs of care or to create a health system that creates true insurance for sick people and doesn't allow the system to have the sickest people carry the biggest burden of expense. So we need to create equity across the economic domain, and we're seeing this emerge in a lot of innovative ways in a variety of different markets. So I think that's really where the future for us will lie. All of these things will create headroom for innovations, whether or not those are drug innovations or device innovations or systems of care innovations. It's affordable, but it does require disruptive entrepreneurial spirit and an ecosystem that agrees to work together to accomplish it. Thank you.
Thank you very much. Thank you for your comments. We highly appreciate your deep knowledge in the situation here in Greece, and we strongly believe that together the public and the private sector can work together to create the appropriate environment for a sustainable healthcare system, because it is time to distinguish here in the country the difference between a state-run health system and a public health system, because in a public health system, the state and the private sector create synergies for a better healthcare system. If I was to highlight a word from what the three of you said, I would keep in our minds from Mary the word disruption, from Sarbani the word guidance, and from Julie the word regulatory predictability, because this is something we really need in order to plan accordingly for the future. Before I open the session to questions and discussions, I would like to make a question to each of you, and then give the floor to all of you So, Mary, you have deep knowledge of the interactions between business and the government at national and European level because of your previous experience in the government, not only in the healthcare sector, but in the industry sector. So we would like to know how health policy can be combined with industrial policy and address the needs of a healthcare system.
Well, just to pick up what Julie said in that regard, obviously in terms of regulation, predictability, I'd also say quality. Our health products regulatory body in Ireland would be highly regarded as very thorough, very strict, and we see that as a competitive advantage. And that's one thing. Secondly, I think the environment has to be stable, political environment and the business environment and the incentive environment, if I could use that phrase, that includes taxation, in order to encourage industry with innovation. Ireland is very fortunate that we have major investment from the pharmaceutical industry in Ireland. 9 of the top 10 companies have major facilities in Ireland, not just basic manufacturing, but bioprocessing, etc. And we've also a lot of development work and innovation taking place, and the same in the medical device sector. And I don't think anybody really comes to Ireland for the market because we're only 4.5 million people. We're sicker than we should be, notwithstanding our youth, mind you. But I think they come because of the business environment, political stability, no matter whether governments change, the policies are maintained, and that's very reassuring. The regulation is good. So how do we work together? I think industry is very good at innovation. At the moment, industry supplies products into the system. I think industry in the future has to be more a partner of the healthcare system, maybe monitoring how its drugs are performing, producing the data. Healthcare systems have a lot of data, but we've very little knowledge, unfortunately. Now, I know there are privacy issues and regulatory issues that have to be dealt with and legal issues, but my God, we're missing an opportunity to be able to use that data to deliver better healthcare. And could I also say, I think our model of healthcare has never really changed. So medical education is very much based on hospital medicine, and payment systems generally are based on interventions. And that's particularly the case in the United States, where they spend nearly 19% of their GDP on health. The Canadians spend 12%, and the outcomes in Canada I don't think are any less favourable than the outcomes in the United States. So as Julie said, sometimes we pay for things that don't deliver results. And the OECD last year in their health report suggested that across the OECD countries, 20% of what we were spending in health was waste. It was delivering no results. So what have we got to do to resolve that? I think industry, patients, and healthcare providers and professionals have to work together. And the patient has to be at the centre. Reference was made to silos. I think we're all siloed. I work a lot with pharma companies, and I find they're pretty siloed too. There's people on the manufacturing and research and innovation side, and other people on the market access side, and sometimes they don't really talk to each other. And we know now that the cost of bringing a drug to the market is at least 10 times more expensive than it was 20 years ago. So I think we all need to be part of the jigsaw, working together around the patient at the centre, and I think this kind of technology allows us to do that. The challenge is to see how we can implement it, and can we get enough people in each system that are up for the change. And I'm not underestimating the challenge, as I said earlier, particularly in Europe, in public sector unionised environments, where there are strict demarcation lines between what profession A does and profession B does and profession C does, so the patient has to keep moving around all these different people. We've got to change that and make sure that the system is moving around the patient and integrating the patient's care. And as Sarbani said, integrated care is substantially cheaper than disintegrated or siloed care, which leads to a huge amount of duplication. I think there are nice pilots in every European country that I'm familiar with, and indeed in the United States. But one thing where I think industry and providers could work together is in the area of adherence. It's been shown that 6 months after somebody's prescribed medication, on average, half the patients stop taking it in accordance with how it's prescribed. Research in the US suggests that's 13% of the health budget. Now, it's in the interests of both industry and patients and the healthcare system that we work together around adherence. And technology certainly can play a role there. I personally know of people who are on medication, for example, if they're on antibiotics, if they feel better after day 2, they don't finish the antibiotic course, highly dangerous. Or somebody that's got diabetes and some days takes their medication and other days they don't. We all know those kind of people. We need to work together. That is a win-win for everybody. It should be easy, and yet non-adherence is actually disimproving rather than improving.
Thank you. Sarbani, we have a lot of instances here in Greece, and I think this is the case across the globe. The governments are reluctant to collaborate with pharmaceutical companies. And let me say that most of the times there is no chemistry between governments and pharmaceutical companies. How do you see the role of pharmaceutical companies in order to overcome these obstacles of working with governments and establish a channel of communication, trust, and collaboration?
So it's a nice question for me, because I remember in 2013 when I left the World Bank, my World Bank colleagues told me, "You're moving to the dark side." And some of them were shocked. They were really shocked that I moved to pharma. And now I've been almost 5 years in pharma. I can tell you, we are like all of you. You know, working with heart and passion on things we care about. But let's just be honest, the reputation of the pharmaceutical industry is not stellar. But one of the issues really is that when you think of the pharmaceutical industry, you think it's a big conglomerate of companies, but each company is different, actually. And sometimes I think the difficulty is because, and I think this is no secret about some of the things that have happened in the United States with certain companies who don't even belong as a part of association. When they do things, the repercussions are for all of us. So I think one of the challenges we face is how do we, as an industry, as a whole, build that reputation with society? Because we don't control other companies. The second thing is, I would say, is that, and we know this, I think Julie would agree with me, we talk about it often. It takes 10 to 20 years to build reputation and just a second to destroy it. So I think we have to look on both sides as this as a long-term proposition. The more we can avoid conflict of interest situations, which we don't actually, we avoid conflict of interest situations, but the conversation has to be around something which is common. And for us, that is about patient and population health, right? Because actually we all care about the same thing, but as I always say, this is like a Venus and Mars conversation. So a lot of the struggle is actually to start having the conversation, starting to build trust, taking a long-term approach, not doing projects with the public sector which are for 18 months or 2 years, but taking a longer-term health systems perspective. And I can really say, and we are working as part of industry group on many joint partnership projects. I see a huge commitment among innovative pharma to be there, to work with governments, to really advance the healthcare agenda. I can also say, and Mary already said it, and this topic keeps coming up, I think we're all for smart regulations, yeah? But when you regulate to the point where you drive out business, that's not a good regulation. So regulations are fine, I'm perfectly okay with it. The other thing is incentives, right? So if you can create a regulatory and incentivized environment and start creating a trust and open the door to working with us, I think we can advance these partnerships. Thank you.
Well, as a recovering politician, I think the pharma industry's image is probably pretty similar to the image of politicians. I think there's a lack of understanding of why drugs cost so much, for example. It's not generally known that for every, I think it's 10,000 compounds, only 2 ever lead to a product. And it takes, 12 years to bring a product to market, and a very few years where you have to make your money back. And effectively, the US is the supporter of innovation because of their pricing model, but that's under pressure. But among the reasons why pharma has a bad name is pay for delay, where companies pay others to delay bringing their generic into the market, where prices of products on the market for 15, 20 years go up by a couple of $1,000%, not because the product has changed, but simply because a new company has acquired the product. These are very hard things to understand. They offend our sense of ethics, I suppose. And it just takes a few companies to do those kind of things for all companies to get tarnished, which is very unfair. I accept that. But I think it would help a lot if industry were more open about and more engaging perhaps with politicians in particular around why their medicines cost so much. Because I know as I engage with politicians across Europe, very few understand why a drug could cost $2 billion to bring to the market. That's not understood, and I think there should be a lot more engagement so that the perspective of industry is more widely appreciated and understood, particularly by those that are making decisions, whether in the European Parliament on intellectual property or in domestic parliaments around regulation.
Thank you. Julie, from prescription to subscription. I was reading an article a couple of weeks ago about the Netflix model in order to reimburse a new treatment in the US. So we definitely moved to such kinds of reimbursement schemes. In an environment which is fiscally constrained, how do you see how can we accelerate patients' access to innovative treatments?
Every government is fiscally constrained when it comes to health and health investments. If anyone knows a country who isn't, please let me know, because I might want to move there. So there are really only 2 choices. One is we have to reallocate the investments that we have to produce greater value, and I talked about some of the ways that might happen, or we have to create business that grows revenue and creates economic opportunity. In terms of reallocation, that's really what we're talking about, but we need to look at the decisions about reallocation holistically. Where would we get the biggest savings in an abstract sense, and then of those, which are politically feasible? I do not know the situation in Greece, but in most countries, hospital care is the most expensive part of care. It is the part growing the fastest, and it is the part that could possibly be best avoided, or at least create the most savings if it were avoided. But unfortunately, reducing hospital care also means reducing hospital beds, which means reducing jobs, and that is not a politically tenable solution for very many politicians. So we have to be realistic about where we can start in these domains. I think the opportunity that's the most exciting from a scientific perspective is precision care. MSD has a cancer drug that at launch was tested in conjunction with a biomarker, because we were working very hard to not treat people who were unlikely to respond to this drug, and to more precisely target the drug to those patients most likely to benefit. Early days of this, but I think we're going to see more and more medicines come forward in an environment where that value is coming from not treating people who aren't going to improve with the medicine. And we have to hold ourselves to that standard and expectation. But in terms of improving the business development, I mean, what we're really saying is, how do you get direct investments in life sciences to drive economic growth? And those could be internally or they could be direct foreign investments, but we really need to think creatively. And I just come back to what I said earlier, you know, in Greece, you're sitting on a gold mine. You're sitting on data that has not been mined. And I see all over the world entrepreneurs investing in how you transform that data into knowledge, as Mary said, but in ways that create information that helps improve the value of care that's delivered and the outcomes that can be derived. And at the same time, not only does that help patients do better in their care, but it's an exportable opportunity for entrepreneurial development. It's one of the fastest moving sectors in the US is the health technology entrepreneurial environment, which is truly an economic driver now. So I just use that as an example to say that, yes, we need to use the investments we make more wisely to produce better health and better health outcomes, but we also have to think about how can we create businesses that do that in ways that also fuel the broader economic growth, which underpins all of our health.
Thank you very much. We have 10 minutes left, so please, for questions. Professor Toutas.
Well, everybody is very happy of all these technological achievements during the last years. But at the same time, I think we have to take under consideration the fact that most of these achievements lead us to a very dangerous path of reductionism. We used to focus on patient, then to systems, then to organs, then to molecules, now to genes. And I am afraid that if we don't see the threat of losing the forest in order to focus on the trees, we might not achieve our main objective, which is to have a healthy population also as a growth factor. That means that we have also to remember that technology has to produce products that can be applied in the area of public health, in the area of health promotion, and also for the second speaker, when we are talking about integrated health systems, we have to think how this integration can also include not only medical or preventive services, but health promotion also services, wellness services, as they have already been achieved in some places in Europe. And for the third speaker, when we're talking about investing in prevention, my question will be how also the private sector can invest not only in prevention, but also in health protection and health promotion, which together with prevention are the three main sectors of the new public health area.
So I fully agree with you on that one. In fact, I think we also know about long-term care, right? In most of the countries, long-term care systems are completely isolated from the health system. But in reality, to have a sustainable support system, you need to integrate both. But I fully agree with you. And the second point, on your second point about health promotion, I actually think there is a huge unleashed opportunity for private companies and the private sector to also step up on wellness for their employees. And having a very sound wellness and health promotion program in the entire private sector can only help governments deliver on their objectives. Thank you.
I'll just add, I think that's exactly what I was implying when I talked about health in all policies, that health doesn't get created in the hospital. It is the employer, it's the school, it's the community, it's the church. These are the places where well-being, mental health, and the things that enable and create a context for health to emerge are created. They are not things that happen necessarily in the medical model, but they are ripe for opportunity and for investment. And an ounce of prevention is always worth a pound of expensive genomic therapy.
I think in reality what we're talking about today is sickness, not health. In fact, only 3% of the EU budget, of budgets across the EU, go into what's broadly called promotion, and that's a big problem. But there are many initiatives at member state level around smoking and alcohol, and many of the drivers of bad health in many countries, including my own, which will pay dividends, but their longevity is often an issue because politicians focus on the next election rather than the next generation, unfortunately. Can I just refer back to something Julie said? I think we do need to dehospitalise care, more care into the community, into primary care. There's no doubt about that. And we do need to close hospitals, or certainly change what the hospitals do, because our hospital system was set up for a very different environment. In Ireland, we have been slowly rationalising what our hospitals have been doing and taking some secondary and tertiary services away from very small hospitals. It has been extremely controversial, mainly because the clinicians in the hospitals reject it, because the elephant in the room is money, and they get the patients on side or the population on side. So I'm a strong fan of trying to bring the clinical class with us on the journey of change, because without that it'll be very slow steps towards progress. But I think it is possible if we can bring clinicians and other healthcare professionals on board the journey of change. I see in one of the newspapers in Ireland today the government are going to pay some of our nurses more money if they move from the hospital to work in the community around chronic illness, etc. And I think we do need to use financial incentives to change behaviour. And let's face it, we're all motivated usually by financial incentives, and I think we need to use them to do the right thing. Very often the financial incentives in healthcare reward the wrong behaviour rather than the right behaviour.
Thank you. It seems that we are not alone on this planet. Next question.
Thank you. We talk a lot now about what the cost of healthcare is, bringing it down, but in a world where you have the posted rate, the insured rate, the billed rate, what the cost is different with every bill and depending on who's paying and how much is where. So how do we, one, know what the cost actually is? And two, how do we make that more transparent when now it really isn't?
I will start. There's no country where this is more of a dilemma than in the United States, where there's basically no transparency and no association between cost and price. And that's true of drugs, but it's also true of hospitalization. One of the former secretaries of health or health ministers in the US was once planning to get a routine screening procedure for colon cancer and called around all the different hospitals in Washington, D.C. to figure out how much it would cost. And he got 13 different, completely highly variable prices, differing by as much as a log. And so, we have no real methodology for making decisions about anything that's priced in the U.S. And that's coming under a lot of debate and conversation right now, and I think that's going to change.
Hi, I would like also an opinion regarding the transactions and the negotiations between a bunch of countries, group of countries with a specific government like the Benelux or the Valletta Declaration.
If I could just refer back to cost for a moment. The former CEO of Kaiser Permanente said at a conference I was at a few years ago that if you have stage 4 lung cancer and if you opt for palliative care, you will live 4 months longer, you'll have a higher quality of life, and it'll be substantially cheaper than if you, as he called it, if you went for filleting, burning and poisoning, which is surgery chemo and radiation. It was just an interesting comment based on Kaiser Permanente research. Ireland has joined the Benelux countries. Obviously, the view is that the bigger the number of countries, the better the bargaining power with the industry. And there was a commitment as a result of joining that all new medications would be made more readily available in the different countries. That hasn't happened yet in Ireland, quite honestly, to do with price and budgets, etc. I still am a fan of countries going it alone, because I think the only way we can afford innovation is if we pay in accordance to our economic well-being. If we were all to pay the rates paid in the poorest countries, then there would be no innovation. That is the reality. I go to India a lot. I'm involved in a pharma company there, and the cost of medication in India is a couple of rupees, like 50 cents, where it might be €10 in Dublin. But the reality is the incomes in Ireland are 20, 30 times higher than they are in India. So if we were all to go down to the bottom, right down to the lowest level, then we would have no innovation. So I think countries going it alone, I know the Benelux countries are all more or less at the same standard of wealth and so on. It's not an easy area. Obviously, within Europe, politicians and member states really want health to be a subsidiarity issue for all kinds of reasons. I was involved in the negotiation on the cross-border directive. It was extremely controversial, and countries were worried about the fact that if we allow people to cross the border and have a treatment in Germany or France from Ireland, we'll have a runaway bill we won't be able to afford to pay. So it all comes back to the money issue, and I believe that if we focus just on cost and care without change, we'll be just rationing healthcare, quite honestly. We really have to focus on the change piece, all of us, whether we're healthcare professionals, policy makers, healthcare providers, industry. Everybody has to be on the one page on the reform agenda. Otherwise, we will be rationing healthcare, and only the wealthiest people will get access to the new therapies that are going to cure us all of everything. I look forward to the day when there'll be a little chip implanted at birth, and it will prevent you getting any illness.
It sounds like a good point to end on. I would just add that, well, maybe, we try to have a philosophy that is very consistent with what Mary described, which is that the value of a medicine is, in some sense, proportion to what a country would have to spend without that medicine. So in the United States, if we avoid a case of cervical cancer from a vaccine, that value is extremely high because it is very expensive to treat cervical cancer in the United States. If we're in Rwanda, there is essentially no treatment, or very little is spent on treating cervical cancers, so the value of vaccination in pure economic terms is very, very low there, and naturally the price of a vaccine is judged accordingly. But I think where we sit as an industry is we're facing a huge dilemma, because it is increasingly expensive to produce drugs. You can argue about exactly what the cost is, and we have to keep our investors interested in investing, and at the same time we have to be realistic about what any payer can afford to put forward for medicines. So how do we get our medicines available at affordable prices to the people who need them now, and at the same time make sure that we can stay in business and continue to try to find the medicines that will cure cancer or treat Alzheimer's or do the things that we know are coming down the pike and are going to be tremendous burdens on society and tremendously expensive absent effective intervention. So it is a dilemma, and I think we have to really work hard to optimize the value that we're delivering for everybody.
I just wanted to add that you're absolutely right that every country is also worried about pharmaceutical prices, but I think you have to go beyond that to look at structural issues in the health system and where you can get better efficiency, because then it's about delivering good quality care to patients. And I think there are three topics, and Julie mentioned this, is generics. Are you maximizing generic use? Second, are you preventing what you can prevent? And the third big cost area in many countries is hospitals. So I think it's pharmaceutical pricing is part of a larger puzzle, but if we look from the health systems perspective, we really have to ask ourselves, have we really identified the cost drivers first and address them? Thank you.
Okay, thank you very much. Ευχαριστώ. Πρέπει να τελειώσουμε, φαντάζομαι, γιατί είναι και το διάλειμμα. Οπότε σας ευχαριστούμε πάρα πολύ. Thank you very much.